Good evening, everyone. Thank you all for attending this webinar. Before I start, I just want to make sure that everybody can hear me and everybody can see my screen. So I am going to ask, you to real quick write on the chat section of this of your dashboard the word yes if you can hear me, and yes if you can see my screen. So okay, I get a lot of yeses, and that is great. Okay, fantastic. All right, everybody can hear me. Yes, yes, some people are saying. Okay, great. Okay, so good evening, everyone. I'm very happy to host you this evening in this presentation. We are going to discuss about some of the reimbursement changes that are going to take place on January 1st, 2017, and more in particular, they are not going to be so much changes in the actual reimbursement, as I am going to explain, but more changes in the way you are reporting some of the things that you will be doing in terms of physical therapy, especially evaluation or re-evaluation starting January 1st of 2017, that eventually can lead and will lead to changes in reimbursement. So we're going to discuss what these codes mean to you and your practice, and I will be introducing a new paradigm to physical therapy. Some of you have heard me talking about this new paradigm to physical therapy in the past, but there might be people who have never been, have never heard me talking about this, so that would be a great opportunity to hear some of the new solutions for this. And if you decide to type any questions as I will be presenting, you are more than welcome to. From time to time, I will be opening the area on the dashboard with the questions, and I'll be answering as much as possible. So if these changes will be nationwide or state specific, the changes that we will be discussing tonight, there will be nationwide changes and not state specific. They will affect every single state. They will not necessarily affect, but we'll get to that. Let's discuss about what changes those will be. But let me tell you a little bit about me. Those of you who don't know me, I have, gosh, actually at this point, I think 30 years of clinical experience in physical therapy. You can guess when I graduated PT school. I've been involved in many areas of physical therapy, manual physical therapy for many years, but also I've been involved a lot in diagnostics for physical therapy. I'm board certified in clinical electrophysiology testing and performing for over 18 years now clinical electrophysiology testing. I am also a member of SAGE, the Specialization Academy of Content Experts, for the electrophysiology board exam. And I am the co-founder of the hands-on companies. Several of these are in the area not only of physical therapy, in the area of diagnostics, in the area of education, and in the area of helping physical therapists around the country establishing also diagnostic components within their practices. Now, let me, as I'm showing this slide, I want to preface this by saying that my presentation to you tonight is a summary, truly a summary of what is coming. The American Physical Therapy Association has very, very detailed information about the changes that is available for free to the members of the APTA, and every single person who is watching tonight, if you are not a member of the APTA, you must become a member of the APTA. That is the source that we have, not only to obtain information, but that is our advocacy organization for the changes that we want to see happening in the future. So what I'm presenting tonight is a very brief summary, but the APTA provides many different tools with this information and a lot more. And as we move towards the end of the year, I have been told that the APTA will be providing even a lot more information to help physical therapists move this process and this change that is coming. So what is the change? Right now, when you perform an initial evaluation, you are using only one single code, 97001. And when you perform a reevaluation, you use the code 97002. Misspelling in the reevaluation, okay. But after January 1st, 2017, while the reevaluation still remains one code, a different code, 97164, the initial evaluation, the physical therapy initial evaluation, will be reported with three different codes, 97161, 97162, and 97163. The code 97001 will be completely removed, as far as I understand, from the available CPT codes for billing, and you will not be able to bill the code 97001 after January 1st, 2017. I am not certain if there will be a grace period. I haven't seen anywhere any announcement about the grace period. What I have seen is that after January 1st, 2017, initial evaluation must be billed using one of these three codes that I am listing right now in the screen. So, why three codes? And what are these three codes? So these three new evaluation codes reflect three different levels of patient presentation. So you have now a low complexity code reflected by 97161, a moderate complexity code reported by 97162, and a high complexity code reported by 97163. Now, what is very, very, very interesting is that despite the APTA's efforts to have CMS assign three different reimbursement levels for these three codes, at least for the year 2017, the three codes will be paid at exactly the same reimbursement level. So no matter which of the three codes you will select to bill for your patients, you will get the same exact reimbursement for 2017. Okay, we don't know what happens after that, but one can suspect that eventually, if you have three different complexity levels, that might mean that there will be three different reimbursement levels for these three codes. But for 2017, there will be no difference in reimbursement on these three codes. Now, what determines which of the three codes you are going to use? Well, there are four different areas that will be used to determine complexity and severity. Those four areas are: one, the patient history. So there, if patient has relevant comorbidities or other personal factors that will affect the level of complexity of that case, that will be a reason, one of the reasons to assign a higher complexity code. Number two, examination. Well, of course, as it is even right now, for examination you have to use standardized test measures. But areas of body structure and function, activity limitations of your patients, and different participation restrictions will also play a role on determining complexity. So differences in the range of motion, manual muscle test, any other standardized test measures that you will provide, the patient's function or activity limitations, what the patient can do and cannot do, and at what level they can do things or cannot do things, or at what activities or even social activities the patient can participate and what they cannot participate. Those will be factors also that will determine these the complexity of the case and the severity of the case in regards to the second criterion, which is the examination. The third area is clinical presentation. There you have three different possibilities. Is this a stable and uncomplicated patient, or this is an evolving clinical presentation with changing clinical characteristics, or we have an evolving clinical presentation but the case is unstable and unpredictable. So in the first case, where you have a stable and uncomplicated patient, it is a simple low back pain, totally muscle related, that could assign a low complexity code of 97161 in regards to this third criterion, because it is stable and uncomplicated. There are no other factors that will complicate this case. Or do I have an evolving clinical presentation with changed clinical characteristics? Perhaps I have a herniated disc in this case, which herniated disc produces numbness, tingling in the lower extremity in a progressive manner. So that is an evolving clinical presentation with changing clinical characteristics. Or I have, in which case, by the way, you would assign a moderate complexity code 97162, and then you have an evolving clinical presentation but unstable and unpredictable. There you can have a situation that is more severe. You have a patient who is involved, let's say, in a motor vehicle accident, and their condition has not fully established. It is unstable. It is unpredictable. So that is a more severe case, not necessarily more severe, but a case with high complexity, where you are going to assign the high complexity code 97163. And finally, the fourth area is the clinical decision making, where you have dynamic interaction between condition and different contextual factors. So those are the four areas that will help you determine complexity and severity. Now, the APTA, and that's why everybody has to be a member, has announced that as we move closer to December, they will be creating and providing a guide that will help therapists properly determine this complexity and severity based on these 4 areas of patient involvement. Okay, I'm trying to read some questions here. So, as I said, the APTA will be providing, as we move towards the end of the year, a guide that will give you a lot more information with specific, perhaps, diagnosis or examples on how you can use these 4 different areas to decide on which of the 3 codes of complexity you are going to use with your patients. Now, let me make clear that none of these codes are timed. So the codes 97161, 97162, and 97163, and the reeval code 97164 are not timed codes. However, there is an understanding, as described by CMS, that a low complexity case might take approximately 20 minutes to do that eval. A moderate complexity case might take 30 minutes for the eval, and a high complexity case might take 45 minutes for the eval. But I am, and a re-eval 20 minutes, but I am reminding you that you are not reporting time spent for the eval, and that is not, the time that you spend is not really a criterion to use to decide which of these 3 codes you are going to use. But the description here of time is a typical time spent, a typical approximate time that you may spend to perform that evaluation. So time per se is irrelevant, but this is a suggested time. Now, what is the meaning of all this, and where we are moving in the future with these changes? I have taken 3 statements from various APTA documents, and I am quoting them here. So I am going to read these 3 statements and discuss them a little bit. So the first statement says that healthcare reform is swiftly moving providers and patients towards value-based payment and away from procedural-based fee-for-service systems. So, based on what APTA is stating in this statement, one can conclude that the direction through which healthcare reform is moving towards, and I don't believe that there is any reason for this to change, we are moving toward a value-based payment system. No longer a system based on what procedures, on what physical therapy procedures you perform, but mostly towards a value-based system. And I will make some possible predictions about this in the next slide that I'm going to show you. Now, the second statement of the APTA is the following. As part of APTA's long-standing efforts to pursue a new payment system that fairly reflects the expertise, skill, and responsibility of physical therapists in caring for their patients and clients, the association and its collaborators developed this three-tiered system of CPT evaluation codes to replace the current single code that covered all physical therapist evaluations. So we see here the rationale, the reasoning that APTA with its collaborators helped to create this three-tiered system of CPT evaluation. And the reason was to create a more fair system that will reflect the expertise, skill, and responsibility of the physical therapist in caring for patients with different levels of complexity, different levels of severity of cases. And the final point here was that the APTA expressed deep disappointment this week that the Centers for Medicare and Medicaid Services, CMS, failed to adopt different payment values to correspond with three levels of physical therapy evaluation that the agency did adopt as new CPT codes in its proposed Medicare physician fee schedule for 2017. So APTA did propose three different levels of payment, three different levels of reimbursement. But obviously, as I explained, this did not become a reality, and despite the fact that you are going to be using three different initial evaluation codes, regardless of what code you use, you are going to be reimbursed exactly the same amount of money. So, is this a good thing? Is this a bad thing? In my opinion, it is not a good thing. In my opinion, it is a bad thing. So, but let's talk a little bit about the future. So, I put there, read my lips. Obviously, these are not my lips that you see in the picture there, but I wanted to make a statement there, read my lips. So, what is coming forward? What are we going to expect in the future? Well, looking from other different professions and specialties, and one of the professions in the medical field that I can take as an example is the profession of audiology. A few years ago, what we witnessed in the profession of audiology was what is called bundling. Actually, we saw that in neurology also in 2013. Bundling. So what is bundling? Bundling is that you take a whole bunch of codes, you bundle them in one code, and you provide one single reimbursement for that code. So just imagine for a moment that an initial that a therapeutic exercise code, maybe with manual therapy, perhaps with some functional activities, they are all bundled in one code. And instead of you billing for specifically what you do for the patient, you do therapeutic exercise, you bill X number of units of therapeutic exercise, you bill for manual therapy, you do manual therapy, you bill for X number of units of manual therapy. Instead of doing that, just imagine that there are three treatment codes that they bundle in their different procedures, and these three different codes reflect three different levels of complexity, and regardless of what you do for that patient, if the level of complexity for that patient is that, this is what you get reimbursed for your treatment. So what am I saying, in other words, is that it is very possible that while right now we have for 2017 3 different initial evaluation codes reflecting 3 different levels of complexity, it is very possible that in subsequent years these 3 different initial evaluation codes will be represented by 3 different reimbursement levels, and it is very possible that since we have 3 different complexity levels for initial evaluation codes, we are going to have 3 different complexity levels for treatment. And these 3 different complexity levels for treatment might have 3 different levels of reimbursement. That is one possibility. Of course, there is another possibility. The other possibility where it says that this is the initial evaluation code, so that patient is, let's say, low complexity patient. So we will pay you a flat fee for the entire episode of care of this patient. Let's say you see a patient with low back pain, they'll tell you, well, we expect that low back pain to be returned back to functional levels with so many sessions, and because we have that expectation, you are receiving that one flat fee for that entire care. Now, those are all possibilities. In my opinion, I see a much greater possibility to have 3 different tiers of complexity in treatment and have a flat fee for each of these 3 different levels. But that is still bundling. Now, look, I do not represent here an association. I do not represent here an organization, a professional organization who may have some limitations as to how much they can say or what position they can take about such an important issue. So I am using common sense. So my common sense says that if we are changing, if we are reforming the system, we are not reforming the system only to just change the way we report something or to make it just more efficient in terms of reporting, maybe with less paperwork, maybe with faster billing. We're reforming it because we need to save money. And that is the reality, whether we like it or not. You see what has been the direction in healthcare. Insurance companies, whether it is government or private sector, their purpose has been to provide a much cheaper care, not necessarily always effective, not necessarily always efficient, but cheaper. So I strongly believe that eventually the reason that this change will take place will not be just to create a more fair system, not just to create a system that reporting is easier, but most likely to save money to the system, to save money to the healthcare system. And those savings will come from a decreased reimbursement for you and me and everybody. So that brings me to discuss with you our current model of physical therapy treatment and what I propose as a new model, as a new paradigm that can significantly empower physical therapists. So right now, what we do is we do a physical therapy evaluation. After that physical therapy evaluation, we develop a treatment plan. There is some treatment intervention based on that specific treatment plan. There is a reevaluation and perhaps an adjustment of that treatment plan. Continuation of physical therapy based on the adjusted treatment plan. And at the end, we have the end of care with whatever program you give to the patient for home exercises and continuation of some sort of exercise involvement on their own and prevention. So this is the current model. So where do I see an issue with this current model? Where I see an issue is right here, right at the beginning. Our treatment plan is based on a mere physical therapy evaluation, a physical examination that we perform on that patient using, special tests with a certain degree of specificity and sensitivity. And we create a treatment plan based on that. And of course, based on any other history and any other documentation and maybe testing, diagnostic testing that we have been provided perhaps by a physician. But perhaps there is no other diagnostic testing that we have been provided by a physician. Perhaps we only have a script, if that, or a patient coming through direct access, or a script that says evaluate and treat. So then our entire treatment plan is based on what we will perform physically with the patient in that room in terms of evaluation. So is it possible that that initial evaluation did not provide 100% the most efficient and effective, the most accurate treatment plan for the condition? Is it possible that the patient underwent a number of treatment interventions here before we did another reevaluation and we said, oh, oops, I just realized that, despite your Tinels and your Phalens were negative and I have been treating your neck for that numbness and tingling in the upper extremity, when I'm realizing now that I have a double crash syndrome, and it is both your median nerve as well as your C6 nerve root irritation. Is it possible that we are missing that and we pick up that piece of information much later in the patient's care? So here is the new paradigm in physical therapy. The new paradigm in physical therapy, right after the initial evaluation and perhaps at a subsequent session, and before the final creation of a treatment plan for patients that are appropriately screened, it includes the performance of diagnostic testing applicable to the physical therapy profession. Diagnostic testing that can be performed by physical therapists and reimbursed to physical therapists. An example of these tests is electroneuromyography. And that patient case that I was describing to you a moment ago with the possible double crash syndrome, we would have found it in clinical electrophysiology testing with nerve conduction testing and an EMG with a 98% specificity for carpal tunnel syndrome and over 87% sensitivity, we would have known it. And again, I'm not saying that this model will apply to every single patient, but definitely could apply to many patients. And of course, in addition to diagnostic testing that you can perform and you can benefit from as a practitioner, of course, that includes diagnostic testing that you can refer out. Okay? And this is one of the things, of course, as you know, that many state physiotherapy associations and even the APTA are trying to achieve, so that we get to be able to refer out also for testing such as X-rays. So now, as I mentioned to you, this is something, the performance of diagnostic testing, it's something that I have been practicing since the mid-1990s. I did my first electroneuromyography study back in 1995, 1996. And I've been performing them since then. My patients have the benefit of having that very important tool. I've been getting reimbursed for these tests. And I have established with my associates a very successful diagnostic business, as I will allude in this presentation. And of course, as I said, this will not be necessarily applicable to every single patient, but definitely applicable to a lot of patients. So since this is something that myself and my business partner have been doing for many, many years now in our state, in New York, which is amongst the 3 lowest reimbursement states, and we have been able to help a lot of patients and also help our practice do exceptionally well financially with the implementation of diagnostic testing, we decided to create an organization that we can help therapists establish such testing in their practices across the country. So in the past 2.5 years, we have now physical therapy centers across 12 different states and in 80 different facilities. So we established this organization, Hands-On Diagnostic Services, that has as a general purpose to create a truly autonomous physical therapy practice by advancing the physical therapist as the provider of choice for electrophysiological, neuromusculoskeletal, ultrasound imaging, and vestibular testing technologies. And because with this model, with this paradigm, we also work with a lot of physicians. We help our partner colleagues to offer valuable diagnostic services to their community, of course, to help thousands of patients and generate significant additional revenue for their businesses, but also to help our MD colleagues out there, offering to them for their patients such services that helps them improve the image of their practices and helps them improve the financial status of their practices, and in turn help patients achieve accurate diagnostic results, resulting to proper treatments and ultimately to healthier lives. And of course, our purpose to the field of research is to create, support, and conduct research in these areas that will provide the necessary evidence for the proper application and utilization of these technologies. We are now performing a series of research studies across several centers that will be able to provide significant evidence for the proper application and utilization of starting with clinical electrophysiology testing. So what tests am I talking about? I'm talking about EMG nerve conduction testing. EMG nerve conduction testing will provide you with information about the neuromuscular integrity of muscles and nerves from your fingertips and toes all the way up to the spinal cord. And then I'm talking about evoked potential studies that will provide you with information about the function and integrity of the nervous system from the spinal cord level to the brain cortex. I'm talking about musculoskeletal ultrasound imaging, and not only joint ultrasound, but neuro ultrasound, ultrasound that evaluates the different peripheral nerves in the body. And finally, VNG, video nystagmography, for patients who suffer from dizziness, vertigo, balance problems, and history of falls. So how does this work? Musculoskeletal ultrasound, for example, is a high-frequency ultrasound that is able to provide you imaging for the different structures under the skin. This is an example of a biceps tenosynovitis. You can see here the biceps tendon surrounded by plenty of fluid, synovial fluid. And you can see it here in two different images, a short and a long axis. You can see a biceps tendinosis, and you can see how the biceps becomes calcified here. You can see biceps calcification. And of course, now that you have a very good idea about what's going on, musculoskeletal ultrasound imaging will not only help you to do an evaluation, but it will help you also in your treatment. Let's suppose that you are doing a neuromobilization technique. You are able to get an imaging of the median nerve right here. This is your median nerve on top. This is the tendon, the flexor tendon on your wrist. This is the median nerve. As it moves, while you are doing a median nerve glide on flexion extension of the wrist. And you can see here in transverse how the median nerve moves away from the different tendons as a transverse glide. This is your transverse glide. And you are able to know how much of that glide takes place and how much it is not, and compare healthy and non-healthy side. And of course, electrodiagnostic evaluation, nerve conduction studies that will be able to provide you with the proper or improper function of that specific nerve, and needle electromyography that will help you do a proper assessment of the different nerves and muscles. VNG testing helps, as I mentioned, in patients with balance problems. So, can you practice all this? Well, this is a map that we obtained from the American Congress of Electroneuromyography, and you can see that pretty much you can perform it in the whole country except New Jersey, Nebraska, and Hawaii. But recently, in our website, www.diagnostics4pt.com, we put there, if you go there right now, we have listed all of the practice acts of all states across the country where you can find out if your state allows and what is the proper language listed in your state about that. This is CMS, of course, approves physical therapists performing, especially the clinical electrophysiology testing. The APTA considers it within the scope of the physical therapy practice. And there are studies out there that show that physical therapists have very high compliance rates for following the specific clinical practice guidelines in the performance of clinical electrophysiology testing. So there is a tremendous need in this industry for clinical electrophysiology and all other diagnostic tests. And of course, Obamacare through the past 8 years of Obama in the government have created maybe many fears, but it has created a lot of opportunities also. And some of these opportunities have been translated exactly in this area of diagnostics for physical therapists. At the same time, a very, very unique opportunity is the fact that in different areas, doctors, because they can no longer make it financially, they start either selling their practices or they become absorbed by large hospital organizations. So this specific model that I'm going to talk about right now, the specific business model, provides a tremendous opportunity for you to capitalize on what is happening in that healthcare environment and help physicians stay afloat, help physicians stay independent in their own practices instead of them having to join a large hospital organization. And I'm going to explain that. Many diagnostic tests are being performed by PTs and reimbursed to PTs, as I explained. Some require certification, and the APTA is an advocate for PTs who perform diagnostic tests. Now, how did Obamacare help? It helped with the Affordable Care Act, Section 1201, and the Public Health Service Act, Section 2706. This is what is called the non-discrimination clause. Based on this non-discrimination clause, an insurance provider cannot discriminate against you and not reimburse you for performing a testing that you are certified or that this is within the scope of your license. So, based on your state law. So this has helped tremendously, and even those through the years, I mean, insurance companies did pay physical therapists for this testing. However, those few that contested, these have been fought now and are being fought, and many of them have been won. I just using an example, in my practice, 95% of the health insurances that we bill, we get reimbursed. Now, what will mean to you if you bring in your practice diagnostic testing, if you learn how to perform diagnostic testing and put it in your practice? You're going to get ahead of the competition. Diagnostics is the leading edge. You can become also a regional source of diagnostics for your colleagues, for other physical therapists who are not able to perform them. You are going to be able to create accurate, evidence-based treatment plans. In many direct access areas, that is definitely the correct solution. You're going to be able to troubleshoot difficult patients very quickly and accurately. You are going to facilitate your relationship with physicians. And of course, you are going to have very substantial amount of reimbursement. Multiples, several multiples, 5 to 10 times multiples of what you are receiving for a single physical therapy treatment. So this is a tremendous diversification in your practice. And actually, the way we have established the entire system of HADs, you are able to start billing and receiving reimbursement for these tests after your first mentorship. So we have a very robust, very specific educational program that can get you to the point to be able to start billing immediately after your first mentorship. So obviously, for someone to learn to perform these diagnostic tests, there is a very steep learning curve. It is a challenge to do interpretation of these tests. And it can be a very high expense without any revenue for months or years until you start practicing. And pretty much every single program that I know out there that may offer some of this testing in terms of educating you, it takes a very long time until you get to learn all this technology on how to perform these tests properly. And definitely, I do not know of any one organization other than HADS that is offering all these four solutions: the electromyography, the musculoskeletal ultrasound, the evoked potentials, and the VNGs, all under one training, all under one roof. So here is the HADS solution. And I am going to discuss with you at this point the HADS Business Development Program. I'm going to see if anybody has a question. No. So what is the HADS Business Development Program? So here is what we do. Within your physical therapy company, we establish a diagnostic component where we teach you how to start testing some of your patients. You bill the insurance company, and we teach you even how to bill. You get reimbursed, third-party reimbursement, the same way you get reimbursed right now for performing your physical therapy, but at a much, much higher rate, multiples of what you receive from a single physical therapy session. That's revenue source number one. At the same time, around your area, there are many physicians that right now, when they want one of their patients to receive an EMG, what do? They send that patient to a diagnostic center. That is loss of revenue for them because they cannot perform this test in-house. Guess what? You solve this problem for them, and you help them to maintain their financial independence and servicing their patients effectively and quickly. So you establish a relationship and you make an agreement of you performing testing, diagnostic testing, in their office. So the physician performs insurance billing, the insurance reimburses the physician, and then you bill the physician a fee for service. So this way you have money that comes to you directly from the insurance company, and you have money that comes to you as a fee for service for performing the services for a physician. The same way that, let's say, a physical therapist may perform a physical therapy session within a physician's office and they get paid for that, the same way they can get paid, but this time for a diagnostic test in multiples of what they would get for a physical therapy session. And of course now these patients who are receiving the testing in the physician's office, they will need physical therapy because they are in pain. Where are they going to go? They're going to go to your physical therapy clinic. And of course, if you have direct access, you can market and obtain not only 3 but 4 revenue sources for your practice. So this is the business model. So how is this training taking place and what makes it very different? So here is what we do. we have divided the entire training for all the different diagnostic tests in modules. So let's take, for example, Module 1. Module 1 is our basic EMG nerve conduction module. So what you do is the moment you sign up with HADS, you take Module 1 online. So you take certain online materials for Module 1. Once you finish, you come to the 3-day live module, Friday, Saturday, Sunday. That live module is dedicated to practice and practice and practice and very intense laboratory with many faculty and assistants helping you to make absolutely certain that you are performing every single technique totally accurately. But that's not all. The moment you finish your live training, we set up a date within the next 2 weeks, and I fly out, for example, or our other faculty flies out to your physical therapy practice, and we perform the testing together. That is your mentorship. And of course, now that you have your live mentorship, you are able to bill immediately for these tests that are performed during your live mentorship. Now, you feel very good, you feel like 90% good at what you have learned, but you may have some doubt. You may have some doubt in terms of the interpretation, let's say, of the testing. Well, that is where our virtual mentorship comes into play. What we do is that the moment you complete a test, we set up your testing machine in such a way so that we get this data from your machine. We look at it, we analyze it, and we provide you with the proper interpretation, or if you have done the interpretation, we provide you with proper feedback, and we come up with an appropriate patient report with proper data interpretation. And of course, we have weekly online sessions, we have weekly symposiums, clinical seminars that you keep improving your expertise on the subject. Then you go to Module 2 and you have exactly the same sequence. So as you move through the modules with these very high intensive method of educating you, we make absolutely certain that you grasp and learn all of the materials at no time. So what I would like to do at this point, I would like to open up the forum for any discussion and any questions that you may have. If you have any question right now, please just type your question or raise your hand so I can open up your microphone to ask the question. And of course, what I would like to do is that those of you who would like to schedule a personal presentation, I would like just for you to put your name down and we will contact you. I have a question from Melissa. I don't know if this is a first name or a last name. The question is, what is the cost of the educational program? Well, Melissa, the cost is not a cost of an educational program per se, because this is a national franchise. And essentially, we help you establish that entire business, and we become not necessarily directly your partners. We don't partner up with you, but we get paid a percentage of what you make specifically from the diagnostic business. And that's how we help you evolve and grow the business. This is not just a continuing education. It's not a continuing education course. Of course, you get plenty of CEUs, but that's not um, that's not a that's not necessarily a continuing education course. I'm getting right now a message here from my friend Rick Gawenda from Gawenda Seminars that he is writing to me that he also has an educational seminar in the area of compliance and the area of the new changes and developments, and I would like to give a definite recommendation for Rick's programs and seminars. They are the top of the line and gold standard in educating yourselves in the area of compliance, in the area of proper coding and reimbursement, and definitely I'm sure, although I haven't checked recently, I'm sure that Rick Wenda has in his website some programs that can help you have a lot more information than what I provided tonight. So Rick, thank you for reminding me to mention that. As I was mentioning before, if you are interested to have a direct presentation, I see here several people saying, typing yes, a direct presentation one-on-one. Do me a favor on the question area, just type your name and your phone number and or email so that we can contact you directly. So let me see if Jerry wants to say something. Jerry, is there something you want to mention here? Okay, I guess not.
Yes, good morning, good evening.
Good evening. Hi, Jerry.
Can you hear me okay?
Yes, go ahead.
Hi. Well, great. Anyway, thank you everybody for coming tonight. I guess I wanted to, if they're interested in talking with us, if they could set a time now, it would be a lot helpful so we don't do the, the back and forth, because I'm sure they get real busy during the week and that. So if you guys could just set a time of when you think would be a good time to meet and go over this in more detail, that would be appreciated, sort of help you and help us. If not, maybe give you some approximate times. So anyways, again, thank you everybody for coming up. And back to you, Jamie.
All right. So basically that's all for now. I do know that several people have indicated that they want a private conversation, and we will make sure to do that. If there are more people who want that, just type right now that this is what you would like, put your phone number so we can contact you, and we will make sure to do that. But again, in terms of the changes that are coming up, please stay tuned. Make sure that you are watching any changes and any developments at apda.org, and we will make absolutely certain, each and every one of us, for the benefit of the profession, that no matter what the changes are, we will all continue not only maintaining the autonomy that we have in the physical therapy profession, but expand it even further to new and greater levels of professional autonomy, so that physical therapy can continue being the #1 solution for people's neuromusculoskeletal problems. So thank you so much, all of you, for staying with me tonight, and have a good night.